Hello everyone, today I'll be discussing on a short topic on ECG, that is the Q wave as well as the pathological Q waves. Here I will be representing an ECG diagram showing P wave, QRS complex and T wave. What does Q wave represent? Before that, in short, I will be describing what is P wave. P wave is atrial contraction or atrial depolarization. QRS is ventricular depolarization or ventricular contraction. T wave is ventricular repolarization. So what is the significance of Q wave? A Q wave, it is the initial deflection in this QRS complex just before this R wave. To assess the Q wave, measure it from the beginning of this descent to up to the beginning of R wave. You measure the depth of the Q wave. A normal square corresponds to 0.04 seconds, one small square. A normal QR variant, it will be, the depth will be less than 2 millimeter with a duration of less than one small square of 1 millimeter and less than 25% amplitude of the following R wave. So in small Q wave, you should note for that the depth should be less than 2 small square and less than 1 small square. So what is the significance of Q wave? Q wave, it represents the depolarization of this interventricular septum. That is the wall separating the right and the left ventricle. So when is the Q wave considered pathological? If it meets any of the following criteria. That is, if the duration is more than 0.04 seconds or 1 small square, if the depth is more than 2 millimeter or 2 small square, if the amplitude is more than 25% of the coming R wave, and if it's present in 2 or more contiguous leads, especially the leads V1 to V3, which is contributing to the septal depolarization. As we said, this is a pathological Q wave in which the depth is more than 2 small squares or more than 2 millimeter and the duration is more than 1 small square or 0.04 seconds. Where do you find the pathological Q waves? It can be seen in 2 or more contiguous leads, which means basically there are 3 limb leads, lead 1, 2 and 3, and V1 to V6, which is the precordial chest leads. The contiguous leads means the pathological Q waves will be present in 2 leads. See, if one AVL and V5 and V6 corresponds to the lateral wall of the heart, and if any MI has occurred previously, the Q waves will be predominant in these leads. If it had occurred in the septal wall, the V1 or V2 would be predominant with Q waves, pathological Q waves. If the more acute, most common MI, which occurs in the inferior wall corresponds to the lead 2, lead 3 and AVF, it can be predominant in these leads too. What is the clinical significance of pathological Q wave? It's an indicator of myocardial infarction, and once it has occurred, it is developed. They are typically permanent markers of past infarction, and moreover, it can help to localize the region of the heart affected by the infarction. Thank you.